All right. Hi, everyone. We have Dr. Jennifer Kizner with us, and also it's Dysphagia Awareness Month. And I'm so glad and grateful to have her. She is one of my mentors, and also I have known her over the period of time with Kasha, and she has a strong presence with the Kasha advocacy, and have closely worked with her also. So, with all that being said, thank you for being here.
Absolutely. Thank you so much for asking me, Dr. Park. This is great. So excited.
Thanks. Okay, I'm going to do a formal introduction just so then all our audience know as to what such great work you do. So, today I'm honored to speak with Dr. Jennifer Kizner, a renowned speech language pathologist with over 30 years of experience being a speech language pathologist, with 26 years at Stanford Health and working with head and neck cancer oncology and dysphagia management for the past 16 years at Stanford Health Care. Dr. Kizner holds a clinical doctorate with research interest focused on post head and neck cancer rehabilitation, including laryngectomy care, swallowing efficiency, home based lingual strengthening program. I believe that was your thesis for the doctorate speech and language program aimed at improving palatal and lingual pressures. In addition to her clinical and research contribution, she's heavily involved with California Speech and Hearing Associations through advocacy initiatives, supporting medical SLPs and addressing ongoing challenges within our field. She's also a clinical instructor for the FEAS program. I took that course as well at Stanford. Helping train clinicians in instrumental swallowing assessment each year. With that being said, Dr. Kizner, once again, thank you so much. I want to, let's see, we'll start with working so heavily with post head and neck cancer patients and heavily being involved with the multidisciplinary team. What is the main focus as a speech language pathologist that you feel is important?
Yeah, great question. I think before I worked in this clinic, I worked in the acute care setting, and I tell everyone that when you're an acute care therapist, you kind of know a little bit about a lot of areas of our practice, right, with regards to diagnosis and what we could give to our patients to help them improve their function and quality of life. And then I moved over to oncology, and now I feel like I know a lot of information about a small area of practice. So I'm kind of glad that I started out very much so as a generalist, and now really kind of specializing in this amazing patient population. Things that I did not know before I came into this clinic were, first and foremost, we all work within a multidisciplinary team, no matter where you are, what setting you're in, right? But in head and neck oncology, we work really closely with our surgeons, with our medical oncologists, our radiation oncologists, our nutritionists, our psychologists, our case managers. It really does take such a team to help move patients from time of diagnosis through to surveillance post-cancer care. What I like about working in a multidisciplinary clinic here is that we get to see the patients as soon as they are diagnosed with their cancer. So we actually see them before any treatment is recommended, and we get to give the multidisciplinary team our input regarding their baseline function with regard to this new cancer. Right. So, for example, how is their swallowing with this large base of tongue cancer? Are they maintaining their weight? Are they coughing more? How is their speech if they have an oral tongue cancer or lip cancer or throat cancer? How is their voice? So we do our evaluations just like the rest of the multidisciplinary team does. Then we all meet together for what's called a tumor board meeting, where everyone talks about the patient and decides a plan of care. So we, as speech pathologists, have multiple touch points with the patient depending on what treatment is recommended. So for example, if someone has a very small, let's say T1 oral tongue tumor, and they're having surgery only, things that we would be interested in, right, would be articulatory precision at conversation level. What is the patient's profession, right? Is someone a salesperson, a teacher, someone that speech is very important to them? And then also, how are we doing with chewing? Right? Not so much the pharyngeal swallow, but the oral swallow. And if it's surgery only and, everything looks good after surgery with respect to scans and reassessments, then we might have a very short amount of time that we need to work with the patient, right? And then on the kind of flip side, if someone, let's say, has a very large tumor that requires multiple modes of treatment methods, for example, if the tumor is very big, they might recommend like chemotherapy to shrink the tumor down. And then after the chemotherapy, surgery, and then maybe after the surgery, radiation or radiation with the chemo. So in patients like that, there are multiple touch points that we have with the patient regarding changes to their swallow function after surgery, after having systemic treatment, after radiation. So it's an interesting kind of clinic where it's not just we see the person after they've had surgery or after they've had a stroke. We're kind of following them along on the continuum depending on their cancer journey.
Right.
I know that was a lot of information, but hopefully that kind of makes sense to kind of put into perspective, like the difference of working in, let's say, acute care where I was before, or maybe a different clinic versus a multidisciplinary
No, I
oncology.
think that's a great point because you see them at different phases, pre, post, and what would be the effects of radiation and chemo. And we all know as speech pathologists that really, really greatly impacts their overall swallows. Like I have noticed, like in my acute care, if we do a follow-up VFSs after like 6 to 8 months, it's been a sudden downfall with patients at the pharyngeal phase. With that puts me on to my second question. How can post-treatment lymphedema contributes to structure and physiological pharyngeal changes that may increase aspiration risk, especially with, squamous cell carcinoma or post-gastrectomy patients?
Absolutely. So, our lymphatic system is part of our immune system. And anytime you have a surgery or radiation, especially in the head and neck, that can affect the normal flow of our lymphatic system to kind of rid our bodies of viruses and things. So, something that we look for specifically post-operatively or post-radiation is swelling, right? So we can have two types of swelling. We can have external swelling that someone can see, right? Oh, I have fullness in the submental area or in my neck or in the face anywhere, right? Depending on where surgery is. With radiation, I feel like we're learning more and more about lymphedema with respect to what percentage of people get it. Because I think more recently we know that a lot more people can get lymphedema post-treatment. We just don't know the severity, right? We're still trying to figure out the severity. And clearly, if you have lymphedema externally, right, that can maybe affect your moving your neck around. If it's around your throat, it could maybe affect hyolaryngeal movement. You can also get lymphedema internally. And so if the structures on the inside of the throat, right, in the pharynx and larynx are swollen, that's also going to affect your efficiency and safety of your swallow. So it's very important that we're assessing patients at appropriate time points after surgery and after radiation to help manage the lymphedema. Historically, our colleagues from physical therapy and also from occupational therapy that have become, that are lymphedema trained therapists are the people that we would refer out to, right? We would say, okay, you have lymphedema, that's outside what we do, like our scope of practice, we'll send them out. However, more recently, we know that if the lymphedema is affecting speech, voice, swallowing, who are the people who should be treating that? Speech pathologists, right?
Yes.
So there are training centers that will allow for speech pathologists to just do training on head and neck lymphedema. You don't have to become like a certified lymphedema specialist to just focus on the head and neck, but there are a lot of really good training programs that talk to you all about what lymphedema is throughout the body, but our focus really is on the head and neck. 2/3 of our lymphatic system are in the head and neck. They're very superficial, and there's treatments that we actually train our patients to do at home or in a combination of coming into the clinic weekly plus doing at home self-massage, self-compression, and exercise. So that's something that before I moved into the head and neck oncology clinic, didn't even think of that was something that as a speech pathologist I should be or could be doing. And now I know we should be doing if we're working with this patient population who have difficulties with function due to external or internal swelling.
Right. That's true. And I think, if I'm not mistaken, Heather had her talk on lymphedema. I learned a lot in
Yeah.
the March California Speech and Hearing Association. And with that being said, I just had a recent patient where, because of the edema, it was so swollen, and I could see like trace penetrations in between the two arytenoids that went through. And I was like, wow, it took me a while to kind of really look into the VFSs a few times to come up with that. Oh, so that was the edema, and that could be the contributory factor that we need to really work on it with the
Absolutely.
head.
And you can use both FEES and NBS to look at the internal lymphedema. And Heather, as part of her PhD, Dr. Starmer, as a part of her PhD um, program, she worked on revising the internal lymphedema scale. So that's one that we use all the time for our with our FEES patients, where we will look around at all the structures that you see in a FEES and talk about swelling structures as well as how they affect function during the study.
Wonderful. Love it. That puts me on to my research question for you, Dr. Kizner. Can you share more about your research in lingual strengthening and how home exercise programs may improve swallow efficiency and overall pressure generations?
Yes, as you talked about, I did a study as part of my capstone project for my clinical doctorate at Rocky Mountain University of Health Professions. Shout
Yay!
out.
Me too.
And so what I wanted to see was in patients who had partial glossectomies, who were treated with surgery and adjuvant radiation or chemoradiation, could we first and foremost exercise the native tongue, the part of the tongue that was not excised? And also, if we exercise their tongue, did the patients have an improvement in their ability to swallow more or chew and swallow more challenging foods? It was a single subject design study, so I had 6 patients that we did this study with, and I did this study during COVID, so I had to change my methodology around a little bit because we were not able to have patients come into clinic if they didn't need to be during the early stages of COVID. And so we were able to actually send patients home with an IOPE, the Iowa Oral Performance Instrument manometry unit, and have them work week by week to increase their tongue strength or their tongue pressures. Everyone increased their tongue pressures. Subjectively, all participants felt more comfortable and confident eating some more challenging foods and going out to restaurants with their friends and not just having to order soup. Right? I often say
Right.
it's not enough for patients at this point to get the cancer behind them, especially in head and neck. It's also about their function and quality of life after treatment. And eating and socialization go hand in hand. So
Right.
kind of where my focus was of can we, can if the patients are able to not only just eat, but be able to eat things that they did before and socialize, that would be kind of a win-win. We also did like a timed eating task where I had them eat sliced apples, and they were able to take sips of water as they needed. And from the beginning of the treatment to the end, we measured them in grams. We actually gave them scales to take home as well to measure pre and post. And they were able to eat in a time challenge more of the apple at the end of the treatment than they were at the beginning. So that just shows efficiency. Now, again, it was a small trial, right? It was a single subject design trial, but it really showed that yes, we can strengthen patients' native tongues who've been treated with surgery, reconstruction, and radiation. And we can also improve efficiency of the chewing with more challenging solids. So that was very, very excited about that, and was able to have that published recently, and it's in open access for folks to look up.
Wonderful. That's so good. Quality of life. That's what we all work together. Because as you mentioned, yeah, it's a rehab part post cancer because we can't really fix that. But what they can do functionally, socialize and not feel restricted. I love that. Uh, well, now it's I think I'm going to ask you more about the advocacy, Dr. Kizner, because I know you've so heavily involved with CASHA and you've made great changes also with the fees bill in terms of the verbiage. And I think that was a huge win for our speech language pathology and SLP community, especially in California, because, I think we are one of those states which is heavily rule governed. We need to have our passes in place. We can just really start. So I would love for you to talk more about that.
Yeah, we have like the most restrictive language, I think, in the United States with regards to SLPs
Yes.
passing a scope and doing something that is within our scope of practice as speech pathologists. So yeah, as you mentioned, we worked on changing the language within our state licensing board. Initially, we needed to have our ENT physician colleagues say we have to pass 25 scopes in front of them, and they had to deem us competent to pass the scope transnasally into the hypopharynx. We were able to change the language to say, currently says the first 10 need to be supervised by an ENT, but the last 15 can be an ENT or a speech pathologist. And I hope that the next step will be all 25 can be and or either by ENT or speech pathologist, because I do think this is an assessment that is within our scope of practice. So it has been so eye-opening working in advocacy at the state level and moving a bill through Congress to get passed. And I really I'm an advocate for other clinicians, because I think a lot of times people feel like, well, it's just my voice. Like, what? No one cares. Like, can I make a difference? And I say yes. And a lot of what we do at our state level associations are grassroots efforts, right?
Yes,
Things that
absolutely.
are like, we have a group of people, and our goal is not selfish. Our goal is we want to help our patients. We don't want patients to be sitting waiting for an MBS for 3 weeks because we don't have endoscopy that we can offer. We don't have fees to offer because we can't get clinicians trained, right?
Yes,
So
absolutely.
it's not just us, it's we need to help the end user, which are our patients. And nobody ever wants to have a patient on a feeding tube or restricted diet any longer than they need to be. And I'll just put a little plug in that I'm so excited. Starting in July, I will move into a new role within the advocacy committee within CASHA as the VP of advocacy. And I'm really excited to do that. And I just would encourage your listeners who are in California or wherever state you're in to get involved. Your medical SLP voice needs to be heard.
I love that. Yes, that would also help to have more than one person talking about we need that. It's more the people, the better it would be to be well heard. And that puts me on to my last question. Um, Dr. Kizner, in terms of the Dysphagia Awareness Month, what would you want to say to our for all speech pathologists that who are working with dysphagia patients as to have more, more encouragement?
Yeah, I think it kind of goes along with the advocacy. I've been doing this for a long time, and I feel like at the end of the day, I can go home and I can eat whatever I want, right? I don't have to have a soft diet. I don't have to think of my liquids. I don't have to do this. And it definitely pains me when I leave and I know, oh, that this patient is on a restricted diet. And I kind of use that motivation to do what I want to do everything that I can for the patient. I want to empower the patient with knowledge, not just of their anatomy, physiology, but what they can do to help themselves, right? Because sometimes they can get discouraged of like, oh, what can I do? Well, you can get educated. You can know exercises that we can help you with. We probably and maybe still need to have you see our ENT or our GI colleagues, depending on what kind of swallow issue you have and if we need other intervention. But I really try to kind of empower the patients as much as I can with education. So I would kind of encourage all of the dysphagia therapists during this month to really kind of highlight that to their patients too. We are doing the best that we can to get you the least restricted diet. And it is definitely working with each patient as a team member, and you have to meet the patient where they are. And I think that's just so important. You're going to get better outcomes if you do that.
Wonderful. Great. Right. That would be so helpful. And they won't feel that they are on a restricted diet or this diet, and then, kind of getting that line in terms of the wording from a professional. So they feel reassured that maybe down the line they might be able to progress and they won't be restricted on this one.
Yes.
Great. Thank you, Dr. Kizner. This was so lovely. I'm sorry with all the confusion, but I'm glad and we are glad that you're here with us and you were able to share your words.
And I am just so excited for you. I'm so glad that you put, all of these interviews together. I
Oh,
think all speech pathologists should watch this because it really just shows that you really want to get this information out
yes.
to as many people, and clearly a field that you love to be in. So
Thank
congratulations
you.
to you.
Thank you so much. Take
Okay.
care.
Bye.
Bye.